Good day. Welcome to today's lesson. This is lesson 6 for medicine 1. In this lesson, we are going to be talking about typhoid fever, cholera, yellow fever, and malaria. Typhoid fever and paratyphoid fever. Typhoid and paratyphoid fever are life-threatening illnesses caused by the Salmonella typhi and Salmonella paratyphi bacteria, respectively. These bacteria spread through food and water and is common in Eastern and Southeastern Asia, Africa, the Caribbean, and Central and South America. That is to say that it spreads through the fecal-oral routes. Salmonella typhi bacteria multiplies within the cells of the liver, spleen, and in the bone marrow. The bacteria then invades the gallbladder and the biliary system. Lymphatic tissues of the bowels may also be infected. Hence, the bacteria is abundant in the blood and in the urine. Incubation period of Salmonella typhi and Salmonella paratyphi is 6 to 15 days and can be transmitted from person to person. Infections enter the body through the small intestine. That is to say, they are absorbed into the body through the small intestine, then into the blood to affect the various organs. Salmonella is a rod-shaped, gram-negative bacteria. For signs and symptoms, you should expect to see, like in every bacterial infection, a high temperature, usually above 39 degrees Celsius. You will expect to see weakness or general body weakness. It's also known as malaise, stomach pain, headaches, diarrhea, cough, and loss of appetite. Rose-colored spots may occur on the skin of white people or persons of the white race, and chest symptoms may also occur in severe conditions. The duration of the illness without treatment is about 3 to 4 weeks, but with treatment may last for a week or under a week, depending on the management given. For your lab investigations, because this is a bacteria that is affecting the GIT and absorbed in the intestine, because it is abundant in the urine and abundant in the blood, you should expect to do a stool culture or a stool routine examination, which will reveal the presence of the Salmonella typhi or the Salmonella paratyphi bacterium. You can also do a blood culture to identify these bacteria, and you can do a urine culture. In your management, what you want to do for your patient is to administer IV Cipro or IV ceftriaxone. You can also administer fluids in cases of severe dehydration because of the diarrhea. You can serve a well-balanced diet at a right temperature. That is to say, serve hot foods hot and cold foods cold. And establish contact precautions in managing your client. Why you would establish contact precautions is that this bacteria tends to spread through the fecal-oral route. So you touch, it enters your mouth, goes into your GIT, is absorbed through your intestine, cause intestinal issues, and then comes out through the stool. And so you would want to limit how you touch patients' urine, blood, and other body fluids to ensure that you do not get infected yourself or you do not spread the infection amongst your patients. You can also opt to isolate such patients, or you can decide to isolate such patients as part of your nursing management. This is not standard practice in Ghana. However, in the developed world, where the necessary precautions are put in place and the structures are in place, you have to isolate your patient in the management. To prevent Salmonella typhi, what you can do is to ask for drinks without ice, unless the ice is made from bottled or boiled water. This is because water bodies can easily get infected with the feces of an infected patient, and this can spread the infection. And therefore, if you want to have a drink with ice, the water must be boiled. The water used in forming the ice must be boiled prior to the formation of the ice, or must have gone through treatment processing and be bottled and subsequently used to prepare the ice. Avoid popsicles and flavored ice that may have been made with contaminated water. Eat foods that have only been thoroughly cooked and are still hot and steaming. Avoid raw vegetables and fruits that cannot be peeled. So if something cannot be peeled, then potentially you would have bacteria around the fruit itself, and therefore you can easily get the disease by eating such foods. So refrain from foods that cannot be peeled, or wash them very well before you eat them. Keep taking antibiotics as long as the doctor has recommended. Wash hands carefully with soap and water after using the bathroom. Do not prepare or serve food for other people if you have the infection, or if you have come into contact with someone who has had the infection, or if you are nursing someone who has the infection. And wash your hands with soap and water before eating. You have to note that vegetables such as lettuce and cabbage can be contaminated even after they've been washed. And therefore, in the washing, you might want to use adequate amount of salt or adequate amount of vinegar in washing. You would also want to avoid fruits and beverages from street vendors unless they are steaming hot. Vaccination for the disease is also recommended from people moving from areas where there are no infections, little to no infections, to areas where the infections are endemic. Cholera. Cholera is a contagious infection caused by a Vibrio cholerae, which leads to severe gastroenteritis and very watery diarrhea. Vibrio cholerae is a gram-negative curved bacteria, hence its name Vibrio, that looks like a red-shaped comma on a gram stain. You will come to learn about gram staining as you do microbiology. But the Vibrio cholerae looks like a red-shaped comma when looked at on a gram stain. It is positive on an oxidase and usually grows in an alkaline environment. It is important to note where the bacteria for cholera grows, as it is implicated in the formation or in the pathophysiology of the disease. The bacteria has a pili and a flagella that enables it to move within the GIT. This means that it does not need peristalsis. So someone would imagine that the bacteria will go through the GIT as the food moves, but it is not so. Even while the food is being digested in the stomach or in the duodenum, before it even moves, part of the Vibrio cholerae can move ahead of the food and cause an infection. It is also a facultative anaerobe, which means it can undergo respiration and fermentative metabolism. This is to say that it can survive without oxygen. As long as it is in an alkaline media, it can survive. One may wonder how it survives in the stomach, since there is a presence of HCl, which makes the stomach highly acidic. As we discuss the lecture, I want you to pay close attention to how cholera tends to beat the acidity in the stomach. So we are saying that the transmission of cholera is usually through the fecal-oral route, and it implies that consumption of untreated sewage water or food that comes with any water that has been contaminated or food that comes into contact with sewage can spread the disease. It means that uncooked fish or partially cooked fish, raw meat, and vegetables watered with contaminated water can all spread cholera. Improper hygiene after visiting the washroom may also facilitate cholera infections. This is not to say that your own feces can give you cholera when you've not had the infection. This is to say that as you go to the washroom, you may pick up the infection from another person who may have used the washroom before you did. Because if you don't have the infection, there's no way the bacteria would appear in your stool. But if another person uses the washroom who has the infection, and you also decide to use the same washroom, and you do not wash your hand, you can get the infection. The question now becomes, who used the washroom? And so since you don't know all those who use a washroom, even when it is in your room and where they have been, it is important for you to wash your hands every time after visiting the washroom. The incubation period of cholera is 1 hour to 3 days. So because of the flagella and then the pili, it can move even ahead of digestion, because not all digestions take place within an hour. So it can move even ahead of digestion and occur within 1 hour and 3 days of taking in food that has been infected. Risk factors for the occurrence of cholera include people living in endemic areas, such as Southern America, some parts of Asia, and some parts of Africa, namely Sub-Saharan Africa. Persons living in areas with low sanitation, and this makes a lot of sense, because it is people who live in areas with low sanitation who are at most risk of coming into contact with feces or water contaminated with feces. People living in highly sanitary environments can also come into contact with the bacteria. But the difference is that proliferation of the bacteria in such environments may be less likely to occur because of sanitary standards. Also, people with low gastric acidity, such as people abusing antacids or people who have genetically low proton pumps in their GIT, may be prone to cholera. And people with blood group O are also highly at risk of cholera. When the cholera bacteria enters the stomach, it stops producing protein. In other words, it stops replicating and rather conserves its nutrients so it can survive the acidic environment. Once it enters the intestines by the use of the flagella, it moves to the intestinal walls and propels to the mucous layer and attaches itself to the microvilli in the epithelial cells. You remember how the microvilli are on the superficial surface of epithelial cells. This cholera tends to bind to this microvilli and begins to secrete its own enterotoxins. So as the cholera begins to reproduce itself after attaching to the microvilli, it secretes cholera enterotoxins. And note that the organism itself does not enter the cell or does not enter any cell. However, the enterotoxins can enter the cell, and this can be very painful and produce severe diarrhea. Now think about it. What does the intestine, what's the function of the intestines, both small and large? Their functions are to absorb nutrients, and the large intestine in particular is responsible for absorption of water. Here's a case where you have a bacteria releasing enterotoxins that are saying that we don't want any food nutrients to enter. Anything that you're going to absorb, bye-bye, don't absorb. So what is going to happen? Instead of the body absorbing the water forms part of the feces. Instead of the body absorbing the nutrients goes as part of the feces. And instead of the body absorbing virtually anything, all you eat comes out as feces. So in the GIT, cholera toxins stimulate the overproduction of cyclic adenosine monophosphate, aka CAMP, which in turn increases the secretion of chlorides into the lumen of the intestines and inhibits absorption of sodium and chloride back into the cell. This may also cause loss of potassium and bicarbonate and water. Think about it. We are stimulating CAMP. What you are saying is that we don't want anything to enter. We are releasing sodium, chlorides. These chlorides will also soak up as much water as they can from the body cells and then draw as much water as they can into the intestine. So we are secreting it, all of them stay in the intestine. None of you enter the body. All nutrients don't enter the body, and all of it comes out. You are going to be very weak after that. You are going to have signs of hypokalemia. You are going to have signs of hyponatremia. You are going to have signs, all manner of signs all over the body. Dehydration, because there's no water entering the body. And there's obviously no nutrients entering the body. And so you just be blah. Symptoms include unprovoked vomiting. And the vomiting is in copious amounts. You have severe diarrhea, stool that is high in sodium, potassium, chloride. The stool has high concentration of these electrolytes, chlorides, bicarbonate, as well as replications of the Vibrio cholera bacteria, which are ready to infect the next person who touches this stool. Flakes of the mucous layer of the intestine may also be present in the stool. And these flakes look like crustings of snow. I don't know how to explain it, but very small, tiny particles. And this makes the stool look like rice water stew. It gives it a rice water-like appearance. You have just tiny, tiny flakes in the stool. It gives it a rice water-like appearance, and it is very rice water-like. You also have severe dehydration because you are losing too much water. And because of severe loss of electrolytes, you also experience a lot of symptoms. A lot of symptoms relative to these loss of electrolytes. And this can occur as early as 4 to 12 hours after the first diarrhea occurred. It can cause severe metabolic acidosis due to the excessive loss of bicarbs. If you remember your acidosis lectures, in metabolic acidosis, you lose a lot of bicarbonates, and therefore, due to the loss of bicarbs, you have metabolic acidosis. You also have muscle and heart dysfunction because of the excessive loss of potassium. And you also have problems with nerve transmission and nerve impulses because of severe loss of sodium and potassium. Low levels of chloride and low levels of sodium may produce headaches, poor disorientation, poor balance, disorientations, seizures, and coma. Remember that hyponatremia can easily cause edema within the brain. It can easily cause cerebral edema. And therefore, when you are losing excessive amounts of sodium and chloride, you can expect to have mental symptoms. Then symptoms of dehydration may also occur. These include sunken eyes, dry mouth, cyanosis, cold, clammy skin, and then a swollen tongue. You can also have a very dry mucous membrane, and all these things form part of the signs of cholera. For investigation, you first of all use the signs and symptoms, because when a client has unprovoked vomiting coupled with a massive rice water diarrhea with a lot of flakes from the intestine walls, you can tell that this is cholera. So you would use the signs and symptoms to give your provisional diagnosis and to start your necessary precautions, because if you have to wait for investigations to take place before you begin your precautions, you might end up infecting everybody on the unit. And cholera is no joke. It can easily cause an epidemic. Cholera is no joke. In Ghana, in 2015, cholera killed a lot of people in this country. And therefore, start precautions as soon as you identify the symptoms. Investigation is usually a stool culture to identify the Vibrio cholerae bacteria. Treatment, you want to give a 541 IV fluid to replace the lost electrolyte. You also want to administer ORS, and you want to administer antibiotics in severe cases. Most of the time, all occurrences of cholera are severe cases, and so you would want to administer antibiotics as soon as possible in addition to the 541. Antibiotics will include tetracyclines and intravenous ciprofloxacin. You also want to maintain contact and droplet precautions. Contact precautions because anything you touch from the patient's stool can result in the infection. And droplet because you are unsure of what the patient's hand has touched or what the patient's droplets have gone through, and therefore you are unsure whether they can cause the disease also. But mainly you would want to look at contact precautions, but just to be on the safe side, consider droplet precautions also. For treatment, you want to decontaminate stool at every instance. This is because every single bout of diarrhea can cause the infection, and therefore you would want to decontaminate the patient's stool at every instance. You also want to encourage liberal intake of fluids, especially ORS, because of the patient not absorbing enough energy. Most of his food will be through IV. So the 541 is meant to replace all food nutrients lost directly into the bloodstream. Loss of appetite may not permit patient to eat as he normally would. However, you can encourage intake of high caloric diet so that the lost energies can quickly be regained. Note that the patient is likely to vomit this out, but as you are giving your treatment and as you are serving your antibiotics, gradually the bacteria will be engulfed, and therefore a high caloric diet will be necessary for patient to regain his strength as soon as possible and to go into convalescence as soon as he can. Then you also want to serve foods as hot as possible because the Vibrio cholera bacteria cannot withstand heat, and therefore serving foods hot can help prevent the occurrence of the disease. Complications of cholera: you can have severe diarrhea, hypovolemic shock. Severe diarrhea is a symptom, but severe diarrhea is a complication. Dehydration can result from the severe diarrhea. Severe dehydration, which will lead to hypovolemic shock. So hypovolemic shock is another complication of cholera. Coma and seizures are not general signs and symptoms. However, when sodium and chloride losses are excessive, the patient can easily go into coma and have seizures and begin to have convulsions if the patient has genetic predispositions to convulsions. And therefore, cholera can also easily result in convulsions and seizures. Yellow fever. Shall we be the time? Yellow fever is an acute viral hemorrhagic disease. The virus that causes yellow fever is a member of the flavivirus species. And yellow fever was the first virus to be identified in the history of mankind in the year 1927. And most of the cases occurred in Accra. If you trace the history of yellow fever, you would definitely see Ghana as part of the first places where yellow fever virus or the flavivirus was first isolated. This is history. It is transmitted by the Aedes aegypti mosquito. Yellow fever can cause epidemic outbreaks. One outbreak recently occurred in 2015 in Angola. The disease takes its name from the yellow skin and then the yellow eyes that appears on infected persons, coupled with the fever that occurs. with a medical background, you will know that this yellow skin and yellow eyes is simply referring to jaundice. However, because at the time it was not well known, it was simply called a yellow and then a fever, hence the name yellow fever. Incubation period for this disease is about 3 to 6 days. The mode of transmission is believed to occur in 3 cycles. First of all, you have the sylvatic transmission, otherwise known as the jungle transmission. You can also have the intermediate transmission and then the urban transmission. The sylvatic or the jungle transmission occurs in the tropical rainforest when monkeys are bitten by infected mosquitoes, hence are given the virus. Humans that are also hiking, camping, or operating in these forest areas within the jungle can also be bitten by the Egyptian mosquito, resulting in the transmission of the infection. For the intermediate transmission, it occurs when villages or small settlements are close to where these mosquitoes are, which is mainly the jungle. This occurs when semi-domestic mosquitoes are infected by both monkeys and humans in the village setting or areas close to the forest areas as such humans developed the yellow fever. So when you have someone entering the forest and coming back to an area which is close to the forest, what you realize is that more Egyptian mosquitoes breed there also, and they can transmit the virus from this infected person to everyone else as they look out for blood meals. The urban transmission tends to occur when an infected human introduces the infection into a very dense populated area, such as a very big city with a high mosquito population. And in this case, although the Egyptian mosquito is primarily responsible for the transmission of the virus, other mosquitoes come in play and they all share in the glory as they all transmit these mosquitoes to the general populace. Symptoms of yellow fever: you can expect to see the yellow eyes and the yellowing of the skin. You can also expect to have headaches, backache, a lot of vomiting, bleeding through body orifices, and inflammation of the liver. You can also expect to have inflammation of the spleen. The spleen would get inflamed because the spleen is responsible for filtering the blood. As blood is filtered and more of the infected red blood cells, infected cells go through the spleen, and the spleen also the virus also goes through the spleen. It ends up having a lot of infected cells, which causes the spleen to become bigger in size. The liver also tends to become inflamed through portal circulation. As blood from the spleen enters the liver is in charge of detoxification, and therefore as too much toxic substances enter the liver becomes inflamed. This concept is not only particular to yellow virus, but may occur in almost all blood-related infections. When the spleen filters the blood that has been infected, you will note that the spleen becomes inflamed, and subsequently the liver may also become inflamed. You also have jaundice, muscle aches, fever, and bradycardia. Note that death can occur 7 to 10 days after the illness has initially occurred, and the mortality rate is 15%. In investigating the disease, you need to do a polymerase chain reaction test to isolate the virus in its early stages. You may also want to do a serology testing to detect antibodies by ELISA in the later stages of the infection. Note that almost all viruses, in identifying the virus, you need to do a PCR testing or polymerase chain reaction test to identify the virus. For your treatment, what you need to do is you want to isolate your patient and hospitalize your patient immediately. Patient should also sleep under a mosquito-treated net. The reasons why you are doing this is to prevent any mosquito in the area from biting the patient and biting another person, thus transmitting the disease. You also want to provide supportive care in managing the patient. You want to encourage bed rest, administer IV fluids for hydration, and use pain relievers due to the severe pains. You want to refrain from aspirin and NSAIDs. You are refraining from NSAIDs because most NSAIDs are metabolized in the liver. And because of the problems that this disease is giving to the liver, giving an NSAID will only complicate the problems of the liver. Furthermore, in the signs and symptoms of this disease, you will note that there is bleeding. Giving aspirin will ensure that platelet aggregation does not take place as it is supposed to. And if platelet aggregation is not taking place, what you will notice is that the patient might bleed to death. And therefore, you want to refrain from aspirin and NSAIDs. You also want to use insecticide-treated nets in nursing the patient, and you want to spray the patient's room with an insecticide to prevent the spread of the infection within the hospital environment. Death is almost certain to occur when complications set in, and the complications of flavivirus infections or yellow fever include renal failure, liver failure, encephalitis, and bleeding through body orifices. Note that this can cause an epidemic, and therefore you want to take all action to ensure that epidemics do not occur. And these epidemics would occur, if they should, it will occur in Africa, South America, and in Asia, especially in their low-income areas. Prevention of yellow fever, you will want to take a yellow fever vaccine to prevent the disease. And yellow fever vaccines are free or almost next to free in our health centers and in designated health centers. So you would want to take a yellow fever vaccine to prevent the disease. Malaria. Malaria is an acute infection caused by the Plasmodium parasite. The Plasmodium parasite is a single-cell parasite that is spread by the female Anopheles mosquito. Malaria is common in tropical and subtropical regions, including South America, Sub-Saharan Africa, South and Southeast Asia. Types of malaria parasites that we have. There are 5 types of malaria parasites. We have Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae, Plasmodium ovale, and Plasmodium knowlesi. It is important to know how each of these parasites work so you can accurately treat the malaria infection. Note that malaria can easily become resistant to the drug, and currently the best known drug that has become resistant to malaria is, or that the malaria has become resistant to, is chloroquine or hydroxychloroquine. And therefore, you have to note it when you are administering in certain areas, or if at all. Mosquitoes are, people often ask how mosquitoes identify human beings in the dark or at night, or how they identify them at all. Mosquitoes are often attracted to dark spaces and dark clothes. They are also attracted to carbon dioxide. So as an individual breathes in and breathes out, the mosquito identifies the individual and attracts itself to the carbon dioxide. Mosquitoes are also attracted to body smells, especially from the armpits and from the feet. They should explain to you, if you live in a tropical or subtropical area, why mosquitoes often like biting the feet as opposed to the face. This is because of the smell emanating from these areas. Once in the bloodstream, Plasmodium infects mainly the liver cells and the red blood cells. It is important to note that some of the malaria parasites, such as Plasmodium vivax, often binds to the Duffy antigen on the red blood cells. Not everyone has the Duffy antigen. Persons with sickle cell do not have the Duffy antigen, and therefore have a relative immunity to Plasmodium vivax. That will tell you that although SS has its obvious disadvantages, they do not easily get malaria as opposed to other genotypes. Other blood conditions, including thalassemia and G6PD, make the infected red blood cells undergo an oxidative stress that causes the red blood cell to die, or that causes apoptosis on its own. This apoptosis results in the damage to all infected cells, and thus the infection is quickly resolved immediately after it is formed. Again, so despite the obvious downside to G6PD and to thalassemia and to carriers of sickle cell, which is the AS group, they all have a relative immunity to the bacteria, the parasite causing malaria. And therefore, risk factors of getting a malaria is obviously if you are staying in a tropical or a subtropical region, which is one, and if you are of AA genotype. Of course, AA genotypes are regarded as the best for obvious reasons. However, when it comes to malaria, AA is not their friend. Malaria can cause serious complications in children under 5. In pregnant women, it can cause birth defects and can cause miscarriages. in people with underlying conditions such as HIV, it can easily cause complications such as cerebral malaria and lead to death. And in travelers with no malaria experience, it can also cause very severe complications. Malaria occurs in two phases. We have the Exoerythrocytic stage and the Erythrocytic stage. The Exoerythrocytic stage occurs outside the red blood cell, particularly in the liver and the spleen, and then particularly in the liver, but the spleen is also implicated due to close proximity and function. And the erythrocytic stage occurs within the red blood cell. The liver and spleen action takes place before the red blood cell action takes place. And therefore, exoerythrocytic phase comes first and the erythrocytic phase comes second. So in the exoerythrocytic phase, it occurs in the spleen and in the liver. What happens is that as the mosquito uses its proboscides to pierce into the skin, Plasmodium in the development stage in the mosquito saliva is called sporozoites, is released into the bloodstream. These sporozoites quickly make their way to the liver within minutes and begin to multiply asexually. And this multiplication is known as schizogamy. P. falciparum, P. malariae, and Plasmodium knowlesi is known to begin to develop after 1 to 2 weeks. They multiply asexually from sporozoites to merozoites, whilst the liver cells die off. Plasmodium vivax and Plasmodium ovale are known to go into dormant stage within the liver for a very long time, for months, and they are known as hypnozoites. Hypnozoites do not show any signs and symptoms and do not multiply, and they are usually asymptomatic. In fact, the entire exoerythrocytic phase is asymptomatic. Erythrocytic phase. They generally last for 2 to 3 days. Merozoites are then developed within the liver. So sporozoites grow to merozoites within the liver, and the merozoites are released into the bloodstream. As they bind the red blood cell, that is where the erythrocytic phase begins, and it generally lasts for 2 to 3 days. It binds to the surface receptors, or the Duffy antigens, on the red blood cells. P. ovale and P. falciparum are known to bind generally to red blood cells of all ages. So ovale and falciparum bind to everyone. P. vivax are known to bind to young, immature red blood cells, otherwise known as reticulocytes. Plasmodium malariae and Plasmodium knowlesi prefer to invade older red blood cells. If you did your anatomy very well, you know that red blood cells last to about 4 months. Plasmodium malariae and Plasmodium knowlesi bound to red blood cells older than 3 months. Once inside the red blood cells, merozoites undergo asexual reproduction and transformation changes. The erythrocytic phase can be divided into 2. Stage 1. Merozoites look like a ring on the red blood cell, and this is called a trophozoite. Stage 2. Trophozoite grows from the ring stage or ring-formed trophozoite grow into and becomes a late stage trophozoite. That is for stage 2. And then for stage 3, the late trophozoite grows by digesting the hemoglobin, leaving behind a hemozoin. These hemozoins are brown stains that are left on the red blood cell. This is called a schizont. The third stage is the actual replication phase of the cell, in which the parasite undergoes mitosis and ensures that it is released into the blood to affect more red blood cells and cause damage to more red blood cells. After undergoing this third stage, instead of going through all these phases again, not all the merozoites go on to destroy other red blood cells. Some merozoites opt to undergo gametogamy and divide to give rise to gametocytes. And you know that gametes only undergo sexual reproduction. So what happens is that these gametocytes sit within the red blood cell and wait until another mosquito comes in and then suck these gametocytes from the body of the person through a blood meal. Gametocytes sexually replicate within a mosquito to form a zygote. And this replication within the mosquito is called sporogamy. Parasites then develop into an ookinete, and the ookinete later forms an oocyte. The oocyte later ruptures into the salivary gland and forms a sporozoite. Then the process begins all over again. Signs and symptoms include extreme fatigue, obviously due to the damage to the red blood cells which are carrying oxygen around the body. Headache, jaundice, splenomegaly, hepatomegaly, fever, and then anemia. Fever may vary depending on the specific type of plasmodium that infects the patient. In Plasmodium falciparum, fever occurs invariably. It can occur at 48 hours, every 48 hours, every 24 hours, or every 72 hours. And this is known as a malignant tertian fever. In Plasmodium malariae, fever occurs every 72 hours, and this is known as a quartan fever. And in Plasmodium vivax and Plasmodium ovale, fever occurs every 48 hours, and this is known as a tertian fever. So in P. falciparum, it's known as a malignant tertian fever. In P. malariae, it's known as a quartan fever, and P. vivax and P. ovale is known as a tertian fever. P. falciparum obviously causes the worst infections because it occurs invariably. But anyway, that's not the main reason why it causes the worst infections. It causes the worst infections because it generates proteins that prevent flow of blood to the spleen, hence avoiding distractions by the spleen. We know the spleen filters blood and destroys red blood cells that have been infected. P. falciparum releases proteins that ensures that platelets aggregate and therefore it does not go into the spleen to be destroyed by the spleen. I hope it makes sense. And since this virus is not sure exactly where the spleen is, it can release this protein almost everywhere and anywhere. And these can lead to symptoms such as diarrhea, vomiting, jaundice, liver failure when it affects the liver. And this is known as a bilious malaria. As I said, it is not sure where exactly the spleen is. And so this release can take place anywhere and everywhere. And so it can also result in ischemia to vital organs because blood is no longer flowing to these vital organs. And thus result in organ failure, like in the lungs and in the kidneys, creating a sepsis-like symptoms which may eventually lead to death if untreated. Mental symptoms may also occur if these proteins are released near the brain, or if this parasite crosses the blood-brain barrier and enters the brain. It can cause seizures, altered mental status, and coma as it occurs in cerebral malaria. For lab investigations, you want to do a full blood count to note thrombocytopenia, and you also want to note anemia. When 5% of red blood cells are destroyed, know that complications are likely to occur, or a poor prognosis is expected for that malaria infection. You can also do a blood test to note elevated lactate dehydrogenase due to severe hemolysis of red blood cells. Remember that we stated before that there are 5 million red blood cells in an average adult. If you have 5% of 5 million being destroyed, that is about 250,000 red blood cells. And that alone is a huge number per mil. That is a very huge number. Therefore, if you have 250,000 per mil of red blood cells being destroyed, I mean, you can imagine. So it releases a lot of lactate dehydrogenase into the blood, and you can measure this through blood testing. A rapid diagnostic test or a thick blood smear can also locate the parasite sitting on the red blood cells. And a thin blood smear or BF for malaria can locate the specific Plasmodium species that is involved in the disease. Treatment mostly depends on the age of the individual, age and weight of the individual, the severity of the infection, the pregnancy status of the person, the local malaria resistance, and the species of parasites. Note that the severity of the infection can even dictate we knowing the type of parasite that's infected, and to also dictate the dosage of the anti-malaria drug we should give. The age and weight, like every other medication, dictates the amount of medication that we should give. Pregnancy status. Most medications, with special exception to quinine and clindamycin, tends to have an effect on the baby, particularly in the first trimester, and can easily cause an abortus. And therefore, we would want to avoid certain malaria agents during the first trimester. Therefore, pregnancy status is important in the management of malaria. Local malaria resistance. As I mentioned at the beginning of the lecture, chloroquine is highly resistant to malaria in Africa today. And therefore, chloroquine is not mainly the drug of choice in the management of malaria. The species of the parasite also dictates how aggressive the treatment should be. since we know some parasites can cause more severe symptoms than others and more severe complications than others. Medications used in treating malaria include artemisinin-based combination therapy, and this includes artemether-lumefantrine, artesunate-amodiaquine, etc. Artemether-lumefantrine is another name for the popularly known Coartem. And these ACTs are a combination of 2 or more drugs that work in different ways, and both come together to cure malaria. And this is usually done in cases of resistance or in cases to prevent resistance. Chloroquine phosphate, like I've already mentioned, was the best drug or the first drug of choice for treating malaria. However, as time has gone on, resistance has taken place, and therefore it is no longer in frequent use. Other malaria drugs include melarone, quinine sulfate with doxycycline, mefloquines, and primaquine phosphate. Note that quinine and clindamycin or doxycycline is used in treating malaria in pregnancy. In this part of the world, pregnant women are often given the anti-malaria drug at 21 weeks so that malaria in pregnancy is totally prevented. Mefloquine and sulfadoxine pyrimethamine are often avoided in the first trimester of pregnancy. In malaria, you would also want to refrain from taking paracetamol because paracetamol has implications on the liver and puts excess stress on the liver. Reoccurrence may occur in the treatment of malaria, and there are 3 classifications of reoccurrence. We have the recrudescence. Recrudescence is simply when you took the treatment as you were told to, or you took the treatment partially like you were told to, and all the parasites did not clear from your bloodstream. Relapse tends to occur when all parasites cleared from your bloodstream, but hypnozoids were left in the liver, particularly in Plasmodium vivax and Plasmodium ovale infections. Then you have reinfection. Reinfection is the most common cause of reoccurrence, where in reinfection, a person is totally cured of the disease and then gets bitten by another mosquito at a later time and gets reinfected with the disease. To prevent malaria, what you would want to do is to bath before you sleep. Bathing before you sleep eliminates smell from the body of the human being and therefore limits the attraction of mosquitoes. You would also want to put on full body clothing that covers all parts of your skin or all parts of your body, obviously to prevent the direct contact of the mosquitoes' proboscites to your skin's epithelium. Then you want to use insecticides within your rooms and on your verandas or within the building to kill all insects, including mosquitoes, present in the building. You also want to empty all containers and stagnant water bodies around your house that may serve as a breeding ground for mosquitoes. Some people opt to pour oil on the surface of stagnant water so that the mosquito larvae can be choked or suffocated to death. However, in large quantities, you may not be able to have enough oil for every inch of the water. You also want to use an insecticide mosquito-treated net to prevent occurrence of malaria. Clear bush around your house where the mosquito can potentially be hiding in. Sitting outside at night in endemic areas should be discouraged so that malaria can be prevented. And vaccination of people traveling from other areas to tropical and subtropical areas, as they may easily get the malaria infection. For complications, clients may suffer liver failure, kidney failure, lung complications, as well as cerebral malaria.